This is a Columbia 75 video on hyponatremia. In this video, we will discuss the core concepts that will allow you to understand the approach to hyponatremia. In a separate additional video, we will use these core concepts to illustrate a scenario involving two patients, and in another video, we will construct a thorough differential diagnosis. Dr. Brian Block will take it from here. Here's Brian.
A good place to start is to define, mechanistically, why we worry about hyponatremia. Well, at the cellular level, a low serum sodium concentration is important primarily to the extent that it may indicate decreased serum tonicity. This is because low serum tonicity creates a driving pressure for water to flow from the extracellular space to the intracellular space, which causes cell swelling and dysfunction. So what is tonicity? Tonicity is a measure of effective osmoles. Effective osmoles are those solutes that cannot freely cross cell membranes, solutes such as sodium and glucose. These osmoles are called effective because they can form a driving osmotic pressure for water to move across cell membranes. Urea, by contrast, is not an effective osmole because it can cross cell membranes and therefore does not create a driving pressure for the movement of water. So we care about hyponatremia to the extent that it contributes to low tonicity. This brings us to the first step in approaching a patient with hyponatremia. Step 1. Determine whether the sodium value you encounter is actually reflective of a low tonicity. So this is important because hyponatremia can actually occur at any tonicity, hypotonic, eutonic, or hypertonic. This is in contrast to hypernatremia, which is always a hypertonic state. A straightforward equation shows us why. See, serum osmolality is calculated as 2 times the serum sodium plus glucose divided by 18 plus BUN divided by 2.8. Normal serum osmolality is between 275 and 290. So if the osmolality is less than 275, then by definition, the osmolality, and therefore tonicity, is low. There are very few causes of hyponatremia with a normal or elevated serum tonicity. One set of causes, called pseudohyponatremia, occurs in the setting of hyperlipidemia and hyperproteinemia, both of which interfere with the lab measurement of serum sodium. In these cases, the serum sodium concentration is normal, but the lab improperly measures it as low. This is why it is called pseudohyponatremia. A second, much more commonly encountered scenario is that of other effective osmoles causing movement of water outside of cells, diluting sodium. This can happen with glycerol, mannitol, or more commonly, glucose. So what happens when you add another effective osm to the extracellular space? Well, this creates an osmotic gradient, drawing water out of cells. As water is drawn out of cells around a fixed amount of sodium, the sodium is diluted, decreasing the sodium concentration. This is termed either a dilutional or translocational hyponatremia. Many people incorrectly refer to this as pseudohyponatremia, which it is not. The sodium concentration really is low because it has been diluted by the movement of water. However, the plasma tonicity is not low because the decrease in serum sodium is made up for by other effective osmoles, those that drew water out of cells in the first place. You can actually calculate a corrected sodium level in the setting of hyperglycemia, which is useful and one of the first things you should do when you encounter a low sodium on a Chem 7. The equation for this is straightforward. Corrected sodium equals measured sodium plus glucose minus 100 divided by 100 times 2.4. Let's return to our approach to hyponatremia. We've done our first step, which is to determine whether the low sodium value is reflective of low tonicity, and we understand why this is important at the cellular level. What's the next step? Now we have to determine whether the sodium is low due to a problem of water intake, water retention, salt intake, or salt excretion. Some of this information will come from taking a good history, but urine studies are also necessary. In reality, the next 3 steps can be performed in parallel, but I'm presenting them in this order because it makes it the easiest to understand. So step 2, measure the urine osmolarity. Urine osmolarity tells us about the action of the hormone ADH. In a normal human, urine osmolarity can range from approximately 50 to 900. When the urine osm is less than 100, we can infer that ADH is not active as the urine is so dilute. By contrast, when the urine osm is greater than 100, and in particular when it is greater than 300, we can infer that ADH is being actively secreted, causing reabsorption of water in the distal nephron, leading to concentration of urine. In most cases of hypotonic hyponatremia, ADH is going to be on, either appropriately or inappropriately. The only cases in which ADH is off are those of increased free water intake, which we term psychogenic polydipsia, and decreased solute intake, of which there are two, the proverbial tea and toast diet and beer podomania. In these cases, excessive water intake or insufficient sodium intake leads to low serum sodium concentration despite maximal excretion of water. So to recap, in a patient with hypotonic hyponatremia, check the urine osm, and if it is low, ADH must be off, and the patient either has very low solute intake or has excessive water intake. As I said before, in the majority of cases of hypotonic hyponatremia, ADH will be on, and the urine osmolality will be elevated. In these cases, you must perform steps 3 and 4. Step 3. Determine the volume status as either hypovolemic, euvolemic, or hypervolemic. Using a combination of history, exam findings, and laboratory studies is best in making this determination. Did the patient recently have nausea or vomiting, diarrhea, decreased fluid intake? Were they outside playing sports on a hot day? Do they have a history of heart failure, cirrhosis or nephrotic syndrome? Have they noted edema, orthopnea, or PND? Has their weight been changing? The most objective and sensitive physical exam findings of hypovolemia are dizziness upon standing and an increase in heart rate of greater than 30 beats per minute on standing. Decreased axillary sweat is also a good indicator of volume depletion, while moist mucous membranes argue against hypovolemia. Capillary refill and decreased Sternberger are generally not of diagnostic utility in the adult patient. Once you have determined whether your patient with hypotonic hyponatremia is hypovolemic, euvolemic, or hypervolemic, the last step is to incorporate the information you already have about urine osmolality and add in one more piece of information, urinary sodium concentration. This brings us to step 4, measure the urine sodium. The urinary sodium concentration tells us whether the kidneys are retaining sodium or losing sodium. The renal response to a low sodium level should be to retain sodium. As serum sodium levels decrease, filtered sodium load will decrease, reducing the amount of sodium that reaches the juxtaglomerular apparatus, causing an increased release of renin, which will in turn cause angiotensin and then aldosterone. Aldosterone, you will recall, augments renal sodium reabsorption through its action in the distal nephron. So, if you see someone with a low serum sodium concentration and the urinary sodium level is low, then you can infer that the kidneys are appropriately conserving sodium. If the urinary sodium level is high, however, then the kidneys are losing sodium. So what level of sodium is used to form this cutoff? In general, a urinary sodium level less than 20 is considered to be low, while one greater than 20 is considered not to be low.
That concludes this video on the approach to hyponatremia. We suggest that you watch these additional videos to see the differential diagnosis and to see a scenario where we will discuss how to apply the concept of tonicity to 2 hyponatremic patients. Thank you.